From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello and welcome to our listeners around the world. You're listening to JAMA Dermatology Author Interviews. Thanks for joining us. I'm Dr. Adamson, the web editor for JAMA Dermatology and host of this podcast episode. Skin cancer is a frequent long-term complication after solid organ transplantation, with approximately 8% of all transplant recipients developing a skin cancer during the post-transplant period. Compared with the general population, the risk of developing cutaneous squamous cell carcinoma is 20 to 65-fold higher. For basal cell carcinoma, it's 7 to 10-fold higher. And for melanoma, it's 2 to 3-fold higher. And when these cancers develop, they often are more aggressive, and some can even be deadly. One strategy for prevention is screening, especially those patients at the highest level of risk. In 2019, a group of researchers developed the SunTrack prediction tool, which stands for Skin, Ultraviolet, and Neoplasia Transplant Risk Calculator, which stratified solid organ transplant recipients by level of risk for the development of their first skin cancer during the post-transplant period. Despite the development of this tool, there hasn't been much real-world evidence on the effect of implementing SunTrack on health systems. But in a new study in JAMA Dermatology, researchers evaluate the impact of SunTrack-based surveillance program called KP SunTrack on screening rates, skin cancer incidence, and healthcare resource utilization. Today, we have Dr. David Lee, who is a board-certified dermatologist and researcher who works at Kaiser Permanente in Northern California, where he's also the regional transplant dermatology lead. He's the first and corresponding author of this work, and he's here to discuss this finding. Welcome to the podcast, Dr. Lee.
Hi, Dr. Adamson. Thanks so much for having me on today. For those listeners who don't know, Dr. Adamson and I were co-interns together many moons ago, and I just think back fondly on all the memories that we have. We've definitely come a long way since then.
Long way. And fun fact about Dr. Adamson is that he gets up before the sun rises to go to the gym and keep that body healthy. Yeah, that was the one thing as an intern that I wanted to make sure I did was, take care of my physical health. So I wake up super early before rounds to hit the gym. I've fallen off a bit in my older years, but I'm glad that that's still legendary. Well, I'm really happy to have you on the podcast. When I was picking which article to highlight, I didn't realize it was you until I read the full article. I was like, wait a second, it's Dave. So I'm really, really happy that you're here. And for those of you in the audience that might not be familiar with Dave, can you tell us a little bit about your role at KP? What kind of patients you see? Are you primarily a researcher or do you see mostly patients? Can you familiarize yourself with the audience a little bit?
Yeah, I don't consider myself a researcher first. I do consider myself first and foremost the clinician, seeing patients directly in clinic. I practice general dermatology at Kaiser Permanente in the Northern California region. We serve approximately 4.5 million members. Over time, including during residency, a lot of that stems from some of the anecdotal clinical scenarios that have come up. We all know those patients who've developed those catastrophic skin cancers or even died from their skin cancer as we follow them along after their transplant. And, one observation that I made, and I know that many of us have made over the years who've been in practice for a while, is how there are some patients who we screen every year, but never go on to develop skin cancer. And I thought that was kind of an interesting pattern that we noticed. And we actually noticed that as an organization as well. And that's what prompted us to dive more deeply into looking at risk in this population.
So what I was hearing is that in this transplant population, because the levels of risk vary depending on the clinical characteristics and demographic characteristics of patients, there were some patients that were probably unnecessarily getting screened too frequently, and there were some with quite the opposite problem. And so you wanted to come up with an intervention in order to sort of remedy that. Do I hear you correct in that assessment?
Yeah, that's correct. Back when you and I were in training, the dogma was that every solid organ transplant patient was at the same universally high risk for skin cancer after their transplant. Though our understanding of the risk is that it actually falls along a spectrum. And so that's what prompted us to take a closer look at risk in this population.
So you assessed, your organization assessed that there was an issue around screening in patients with history of solid organ transplantation. And you decided to use SunTrack as a tool in order to risk stratify patients. Can you explain to the audience what is SunTrack and what are some of the components that make up the risk calculation tool?
Yeah, SunTrack was developed in 2019, so about 6 years ago, from a large multi-center US-based study of more than 6,000 solid organ transplant recipients. They model risk into 4 categories, including low, medium, high, and very high risk based on 5 well-established risk factors that we're aware of, including age at transplant, with an individual at higher risk if they've had the transplant after the age of 50, male sex, lighter skin phototype, which in the study was approximated in the original model by race and ethnicity, thoracic organ transplant, as well as a prior history of skin cancer before the organ transplantation. So it's an elegant and simple tool that's available online for free, and it allows us to calculate an individual's specific risk on developing post-transplant skin cancer. So it's very useful right at the bedside.
And you did something a little bit different with this tool because you added a KP on it. I'm assuming it's for Kaiser Permanente. What was the difference in the kind of utilization of this tool? Did you add a few aspects to it?
Well, SunTrack itself is designed to be a tool that's implemented at the time of transplant. So it's somewhat of a static tool. While it does predict the risk of skin cancer after transplant longitudinally, it doesn't account for what to do after that initial screening is performed. And so what we did at Kaiser Permanente is we maintained all the same variables that go into SunTrack, and we also wanted to account for those patients who develop skin cancer after their transplant. So let's just say if you're a low-risk patient and you develop a skin cancer after your transplant, should we follow those patients? Of course we should. Your risk of skin cancer does increase significantly after that first post-transplant skin cancer. And so with our surveillance program, we started off as a targeted surveillance program for higher risk individuals. So we actually launched this program in 2 phases. The first phase was launched in 2022, and we targeted higher risk individuals for screenings in dermatology. In terms of the mechanics of the program, we leveraged the electronic health record data as well as a software algorithm to identify every transplant recipient within our membership, and we automatically assign them into original SunTrack risk groups. Dermatology focused initially on the high and very high risk individuals, as well as anyone who had developed a skin cancer after their transplant. And we reached out to those patients directly through multiple means, whether it's by online messaging, through the portal, emails, telephone encounters from our staff, to schedule them into dermatology for at least an annual total body skin exam. And the unique aspect of this is that it did not require any referral from any other specialty. And that was the focus of our current study. A few years later, in 2024, we've launched the same program for our lower risk patients, so those in the low and medium risk groups. And we targeted them for annual screenings in the primary care setting with a streamlined process and agreements among departments for rapid dermatology referrals if any concerning skin lesions were identified.
So you implemented this program, and in the paper, you have pre and post implementation numbers associated with a number of factors, like whether a larger proportion of people were screened or not. You looked at utilization as well of health services. Do you mind telling the audience kind of what were the high-level findings from this study?
Yeah, so we split the study into essentially 2 sub-studies. And in the first study, we just really wanted to confirm, is the SunTrack data reproducible in our own patient population? And we found that it was reproducible. We were able to generate skin cancer incidence curves that mirrored those in the original SunTrack study, as well as several subsequent external validation studies in Europe.
Yep, that's promising.
Yeah, and we wanted an updated snapshot of what the skin cancer risk was in our population as well. A lot of the data that we refer to and commonly cite to our patients is from all the way dating back to the 60s. And so we wanted that updated snapshot. We found that our transplant recipients had a nearly 8-fold higher risk of skin cancer when you compare them to non-recipients. And that risk is even more elevated for cutaneous squamous cell carcinoma, where there's a nearly 11-fold increase. But that's still quite lower than the 65 to 250 times the risk that we commonly talk to patients about, right? And I think there's something to be said about skin cancer incidence rates going down in this population. I think that has a large part potentially to do with what we do in counseling our patients, awareness, chemo prevention, and active surveillance in this population.
We can't really say that they went down. We just know that they're lower than other studies.
That's exactly correct. And another factor that may influence our findings is that we had a sizable portion of patients who were skin of color, so about almost 70%.
And this includes people that identify as Asian, Native American, and also people that identify as, quote, other, right? Well, that's where they take other off in the electronic health record as well.
Right. And we had a relatively higher proportion of abdominal organ transplants. And as we know, they undergo a little bit lower immunosuppression, maybe not subject to some of those antimicrobial treatments that we know can increase the risk of skin cancer after transplant. In terms of other outcomes, in the second study, we found that post-implementation, the screening rates actually improved significantly after launching KP SunTrack. And so people in the post-implementation group who are higher risk range anywhere from 122 to 174% more likely to be screened after implementation when compared with before implementation. So that was a meaningful finding, which indicated that the program actually improved screening. In terms of skin cancer incidence, we found that the post-implementation group had a 2.6-fold higher risk of having a first skin cancer diagnosis after their transplant, which in my mind suggests that we were detecting cancers in that post-implementation period that may have otherwise gone undiagnosed. What was actually the most important and perhaps the most surprising to me was that resource utilization, and this is something that we measured by appointment counts related to skin cancer and skin neoplasms, as well as pathology specimen counts. Those actually remain stable or not significantly different, rather.
What about some patients that may be overutilized screening? Or did you find any evidence that implementation caused some people to go to the dermatologist or their primary care doctor more frequently than what would be indicated? Is that something that you also looked at?
Well, that's a really interesting question. We didn't specifically address that particular clinical question. One thing that we do observe is that the patients who are in the low and medium risk groups, while we didn't specifically study them, particularly in the low risk group, some of the overall screening rates in the post-implementation appeared to go down. We didn't study it specifically, but it potentially could suggest that without active outreach for screenings, some of those patients may not have been screened as aggressively, but that would be an interesting question to address in the future.
So what's next for this research or the implementation of this work?
The next step is to follow this longitudinally in our population and to see if risk-based screening strategies not only improves, but ultimately our goal is to prevent excess morbidity and even mortality from skin cancer. And unfortunately, our study follow-up period was not long enough to be able to capture that. And I'd say looking even further ahead, while SunTrack is a wonderful tool, we can get even more granular by incorporating additional clinical data and perhaps even using some of the newer technology that's out there, including artificial intelligence, machine learning, to further optimize in this vulnerable population. But the ultimate vision really is to be able to identify skin cancers early in this population and to hopefully prevent some of those catastrophic outcomes that we've all seen in our practice over the years.
What struck me the most about your study in terms of utilization is that you found that utilization patterns didn't increase, even with the implementation of potentially more screening. The math doesn't seem to math. Could you hypothesize why you think that's the case?
I think a plausible explanation in my mind is that when you do structured surveillance at set intervals, and there's this understanding that instead of evaluating just one lesion, you're going to evaluate the entire skin surface area. And so you're performing that full body skin examination. And you're able to potentially capture other lesions of concern to the patient and perhaps even early skin cancers For instance, that tiny little basal cell carcinoma that maybe was overlooked on a spot check appointment. You're able to catch all of those in a single appointment and then kind of consolidate a lot of those subsequent visits into fewer visits ultimately. Now, that's a hypothesis, and that's something that's certainly important to study and to follow longitudinally.
One more question for you. How can clinicians use your study or SunTrack? What is the takeaway that they should have from this work that you have published in JAMA Dermatology?
For individual clinicians at the bedside, it essentially means moving beyond this one-size-fits-all model and then being able to have that nuanced conversation with your patient who may be anxious about their skin cancer risk because of all the messaging that they've received from their transplant team and even from you in the past, and being able to tailor a skin surveillance plan with them with that shared decision making. So I think this really empowers both the clinician as well as the patient to understand what their realistic risk is.
Thank you so much, Dave, for being on the podcast. It's great seeing you again and hearing your voice again. I'm Dr. Adewole Adamson, and I've been speaking with Dr. David Lee about the impact of using SunTrack risk assessment tool for surveillance of skin cancer among patients that have a history of receiving solid organ transplantation. You can find a link to the paper in this episode's description. This episode was produced by Daniel Massisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening. Catch you on the next episode of the JAMA Dermatology Podcast.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.